just a short voiceover over the remainder of the oxygenation lecture. So some other things that we can do from a nursing management implementation standpoint is chest percussion. So a lot of times you'll see respiratory therapists do this as well. And so the goal of chest percussion is to force secretions into the upper larger airways so the patient can cough them out. So patients who have maybe chronic bronchitis, that component of COPD where they have excess secretions in their airway, thick, tenacious secretions. Maybe patients who have cystic fibrosis. Those patients are going to need chest percussion, which is kind of clapping on the chest wall to get secretions up into their upper airways. And you can use like a cupping technique where you almost kind of cup your hand onto their back. And so you just kind of cup it, clap in certain areas on the chest wall. The importance of doing this in these patients who are at risk is because the secretions can kind of pool and create an environment for, organisms to grow and proliferate. And then also, sometimes the secretions, they can get clogged in the airways and cause like a mucus plug, which can cause a collapse of the lung. Contraindications, obviously, if patients have a lot of chest discomfort, they've had a thoracic surgery, open wounds, those might be some contraindications. So those are some ways that we can help open up the airway, maintain patency. So vibrations, a little bit like chest percussion, but you're going to be using little devices that can actually vibrate on the chest. Sometimes there's little vests that people can wear that actually kind of vibrate and shake a little bit. This is just another method to kind of facilitate secretion removal, pushing it up into the larger airway. So that way, it can easily come up with like coughing. All right. And so we talked about if we're not able to help patients get up secretions or keep their airway patent with some of the more natural ways, we can do suctioning. And so we're going to practice in lab on Tuesday nasopharyngeal suctioning. So we're going to go just to the back of the pharynx, kind of where the back of the nose and the oral cavity meet. But with tracheal suctioning, we can go all the way down the trachea into where it bifurcates at the carini. So pharyngeal is not as kind of invasive as the tracheal, but it's still a sterile technique. And then obviously if your patients have tracheostomies and endotracheal tubes, we can suction that way, which is what we're going to have to do for these patients because we've bypassed kind of some of their normal coughing mechanisms with the airway. So this is kind of just an image of like a nasopharyngeal, but it's kind of going down a little bit more into the trachea. This might be like an oral pharyngeal, just cleaning the patient's mouth, good oral care. This is kind of a closed suction technique where we would do this through an endotracheal tube. And then this is more of an open technique where it's not within a closed circuit like the endotracheal tube. And we are going directly into the tracheostomy. So oxygen therapy, we need to remember that oxygen is a medication. It does require a healthcare provider order. A lot of times in the hospitals, coming through the emergency room after surgery, we might need to put patients on a little bit of oxygen to support their pulse ox, their respiratory status, and we would call the physician to get an order after we started it. And sometimes it's actually built into order sets for certain procedures or certain patients who are admitted with specific illnesses such as like pneumonia. Obviously, oxygen therapy is to prevent hypoxia, hypoxemia. We can use it just acutely and temporarily after surgeries or an acute injury or an infection, or it can be long-term with those patients who have chronic pulmonary disease, where these patients are going to need oxygen 24/7, around the clock, whether they're at home or out, or some of them might just need it when they're sleeping. So there's multiple methods of application, which we're going to talk about. But one of the things you need to remember about oxygen is that it's combustible, and so it can easily start a fire. So that's why it's important from a safety perspective that whether it's in the hospital or at home, we need to make sure that there's no smoking around oxygen, nothing that's flammable that can spark, that can easily start a fire. So it's not like it's going to explode, but it can just very easily burn. So oxygen, signs that say no smoking or oxygen in use, those are great considerations. And so in the hospital, we're obviously going to be using a piped wall system for the oxygen, but we always make sure that we have portable tanks that can house a certain amount of oxygen in them, whether it's in the hospital or in the home. So some of the methods of delivery, the nasal cannula, it's probably going to be the most common, simple, convenient methods to use. We typically start these patients somewhere between 1 to 6 liters. There are some newer nasal cannulas that we can do a little bit higher, but more commonly, we're thinking 1 to 6, okay? Anything more than 4 liters, we're going to make sure that it's hooked up to humidification, like a water system, like a water bottle that's connected to the oxygen source and directly to the cannula. And that way, it's going to apply a little bit of humidification to the inspired oxygen to make sure that it doesn't dry out the nasal cannula or the nares or the kind of the airway. So again, we can use this acute after surgery, illness, injury, or a lot of your long-term pulmonary patients will use a nasal cannula at home for their method of oxygen delivery. So room air is somewhere around 22% laced with oxygen. So a lot of times we say like maybe 1 to 2 liters has somewhere between 28 to 32% of oxygen in it and so forth. A simple face mask might be the next step up from a nasal cannula. It's very short term, and it might be appropriate with patients who are mouth breathers. So after surgery, they're still kind of waking up for anesthesia. We might consider a simple face mask. You just have to make sure that you've got it turned up to at least 6 liters, somewhere between 35 to 50%. Because if you have a face mask on somebody and you're not giving them quite enough oxygen, it can actually cause CO2 to accumulate, and so we can actually increase the CO2 in the person's blood. So we need to make sure to avoid that we keep it set at least 5 liters or more through the simple face mask. Because it's a mask and it's kind of adhering to the face at times, we want to make sure that we're monitoring all up and down under the mask for skin breakdown or behind the ears. And kind of same thing with the nasal cannula too. You can get breakdown in the nares, and you can also get breakdown behind the ears. So the Venturi or the Venti mask, it's more appropriate for patients who have chronic pulmonary disease. Venti mask can give a very precise, exact amount of oxygen concentration. Sometimes with simple face masks, non-rebreathers, nasal cannula, it's more of an approximation. It's not exactly precise. In some of our patients who chronically have elevated CO2 levels because of their structural abnormalities or what's happened to them from their disease, we worry about them retaining too much carbon dioxide and making their blood more acidotic. So these patients, if they need higher levels of oxygen than what can be given through a nasal cannula, we sometimes like to put them on a Venturi or a Venti. That way we can precisely evaluate how much oxygen we're giving them so we're not increasing their risk for retaining CO2. So this is kind of a big concept to remember, that Venturi or Venti masks are appropriate with patients who have lung disease that are at risk for retaining CO2. So this is kind of like a simple face mask. This is a Venturi mask. You see you've got like a little adaptation on the bottom that hooks to the mask that allows us to make the amount of oxygen very precise. And then you've got the nasal cannula. All right, so at higher concentrations is a non-rebreather, and you can get it all the way up to about 90%. So once you hook it to the wall and you turn the flow meter all the way up to 15 or turn it all the way up to high, it's roughly about 90% of oxygen. So it's almost just pure oxygen. So there is a reservoir bag down below, and it's kind of what holds the oxygen in there. So we need to make sure that before we put this mask on the patient with the straps and kind of adhere it to the face, that this bag has to at least be halfway full before we put it on the patient's face. I mean, why? It's kind of like you're just putting a mask on without anything. So you need to make sure that there's at least some oxygen in here so that way we're not suffocating the patient when we put it on. All right. So usually when you think of patients being on this, they're very sick and they're kind of at that bridge between needing something more invasive, whether they need to be put on a BiPAP of sort, or they need to be intubated and put on a mechanical ventilator. So these patients need a lot of support. So we usually think of this in emergency situations. But all of these things that we've talked about, whether it's the non-rebreather, the Venturi, or the simple face mask or the nasal cannula, patients actually, they have to be breathing for this to work for them. So if a patient is not breathing, they're breathing very slow, they're not appropriate for them, right? Okay, so a non-invasive positive pressure ventilation. So this is very similar to CPAP, and it can be a form of CPAP. We talked about CPAP with obstructive sleep apnea, where it continuously applies a little bit of positive airway pressure through their airway to kind of keep that upper airway open to kind of prevent the hypoxia, prevent the snoring. We can also do something that's known as BiPAP, which stands for bilevel positive airway pressure. So the difference between BiPAP and CPAP is just, instead of continuously applying pressure throughout the inspiratory and expiratory phase, we do it at two stages. We apply pressure on inspiration, and then we apply a different set of pressure on expiration. And so we do this not only to help improve the patient's oxygenation, we do it to help increase or enhance their work of breathing, or kind of decrease their work of breathing. So if we're applying a little bit of pressure when they breathe in, it helps to reduce their work of breathing. It makes it much easier for them to take a breath in. And then when we do it on exhalation or expiration, we actually can help keep the alveoli open and the airways open to maintain oxygenation and patency. So BiPAP is not something that you're going to see with sleep apnea and CPAP. BiPAP is going to be seen if a patient comes in and they're in distress, and we're trying to prevent from putting them on the mechanical ventilator, or if we need to help blow off some CO2. So it's non-invasive positive pressure ventilation. So whereas invasive positive pressure ventilation would be putting a patient, a endotracheal tube, trach in, and putting them on the mechanical ventilator. So like we said, the purpose of a non-invasive positive pressure ventilation, whether it was CPAP or BiPAP, is to maintain positive airway pressure and improve ventilation and keep their alveoli open. So it's going to decrease their work of breathing, improve oxygenation by ventilating better. So obstructive sleep apnea with CPAP, heart failure, respiratory failure, BiPAP. Okay? So contraindications and nursing concerns. So again, just like we talked about with the regular oxygen methods, these patients have to be breathing. Okay? It doesn't breathe for them. It just supports them. If patients have a lot of abdominal distension, we worry about them vomiting, it might be a nursing contraindication, because sometimes we're putting a lot of pressure in with a mask, or even whether it's by a nasal, you can make the distension worse and actually induce vomiting. And patients are laying down and they're really sick, increases their risk for aspiration pneumonia. So this is kind of like a nasal. This is a little much more sleek, kind of modified. This is what we typically would see on a BiPAP for a patient who really needs full support on a BiPAP. And then this is kind of what the machine would look like in the hospital, and this might be like a bedside machine for somebody who has a CPAP. And this might be what they use at home. All right, so indications for home oxygen. So, not everybody qualifies for home oxygen, where they wear it at night or 24/7. So there needs to be some criteria. So we look at how much oxygen is in the person's blood, and we also look at their oxygen saturation, like what's attached to their hemoglobin. The only way to actually truly get an oxygen in the arterial content is to do what's known as an arterial blood gas. That's something we'll definitely talk about as we move along in the program and in 508. But if the PaO2, or the amount of partial pressure of oxygen in the blood, is less than 55, that might qualify somebody for home oxygen. If their oxygen saturation is 88% or less on room air at rest or on exertion or with exercise, they might qualify for home oxygen. Like we said, oxygen is a medication, so it needs to be prescribed by a healthcare provider. We can do it either through a nasal cannula or face mask. I think in the home you're going to more commonly see it with a nasal cannula. And there's some patients who are on a ventilator long term, or if they have to go home with the tracheostomy, they also might have oxygen that's put in right through their tracheostomy. Obviously the benefits of oxygen use, oxygen therapy is improved activity tolerance, enhanced myocardial contractility, and overall quality of life. So if patients, whose oxygen saturation or the oxygen content in their blood they're weak, they're fatigued, they're short of breath, by giving these patients oxygen, it's going to improve their activity tolerance, what they can do. It's going to make it more comfortable for them to sleep, comfortable for them to eat, get up and participate and engage in their life. And then we know our heart needs oxygen for contractility. This is known as a condenser. These both are. And so they have the ability to take their oxygen out of room air and kind of condense it. And so patients can use it this way without actually having to have it refilled. So it does go by electric, so it has to be plugged in. And so when patients need oxygen in the home, they typically use a condenser, which utilizes room air, the oxygen in room air. And then they also have some backup portable tanks. All right, so from a restorative rehabilitation phase, we know our patients who have chronic pulmonary disease, there are some other options for these patients to rehab. Cardiopulmonary rehab, typically conducted by a respiratory therapist. In some of your patients who have long-standing pulmonary disease, they might meet monthly, a couple times a month, in like a support group or outpatient setting to actually have pulmonary rehab. So they might do physical activities like building their endurance. They might have nutrition counseling. What kinds of things should they be eating? Should they be eating high calories because of their demand with breathing? Should they be eating low carbs because we know carbs kind of turn into acids? Things like that. Relaxation and stress management techniques to kind of help control their breathing. Definitely medication management, how to utilize their inhalers when appropriately, their short acting, their maintenance. And then definitely about managing their oxygen in the home. And then, hydration. We've talked about the importance of hydration to keeping the airway patent and secretions thin. And then there are two different things, too, to kind of consider with your patients who have oxygenation problems. Is their breathing exercise. A lot of times you'll see your patients who have long-standing pulmonary disease, they're at increased risk for CO2 retention because they've got destruction and impairment of their alveoli. So a lot of times when you see them breathing, they'll be breathing with kind of a pursed lip breathing where they breathe in and their expiratory phase is much longer, okay? And they're doing this as kind of more of a relaxation technique, but they're also doing it naturally because it's helping them to exhale more of the CO2 that's kind of being trapped within their alveoli. So pursed lip breathing is kind of a technique that is taught to patients to help control their breathing, relax themselves, and it also helps to remove all of their CO2 effectively from their alveoli. All right. So, some of the things that we're going to evaluate if we're helping a patient who's got an oxygenation problem, and we want it to be measurable, right? The outcomes that we're evaluating. How is their shortness of breath? Is it improved? Okay. Their respiratory rate, that's very measurable. That's a great thing to look at. Has their respiratory rate come down? Did it start at 28, 30? Now is it back down to 16 or 20? And activity intolerance. Have they had the ability to take care of their ADLs, their self-care? Getting up, walking farther of a distance? Are they completing their baths by themselves without any help? Making their own lunch, doing their laundry? All things that we can evaluate to see, okay, have what things that we've done for this patient, are they improving? Are they staying about the same or getting worse? So some safety guidelines again to consider about oxygenation. We talked about that concept of hypoxia, right? Low oxygen content at the cellular level within the tissue. And so some of our changes that we can see with hypoxia, vital signs, you know, in the early stages, we might see an increase in heart rate, increase in blood pressure. And when very severe, prolonged courses of hypoxia, we might see bradycardia. We might see low blood pressure because these patients are getting ready to arrest. Level of consciousness, such as irritability, restlessness, are always first signs of hypoxia. Progressing to lethargy, coma are more late signs of hypoxia. Diffusion, definitely. So patients with COPD, and we're going to talk about this with our COPD lecture in a few weeks, but patients who truly have emphysema changes with their COPD, which means their alveoli are kind of destructed and impaired and they retain CO2, should never have really high concentrations of oxygen on a routine basis, okay? So 2 to 4 liters is kind of the extent, and if we need to put them on higher, we probably need to look at doing a venturi, or maybe even a BiPAP mask. It's just these patients are at risk for CO2 narcosis, increased CO2 levels, and if we give them such high concentrations of oxygen, not only does that return as CO2, but it also can actually knock out their drive to breathe. And that's kind of where we talked about at the beginning of our lecture. Normal things that stimulate us to breathe from our brainstem is decreased oxygen, drop in our pH, increase in our CO2. And some of these patients who have COPD, and they truly have increased CO2 levels, drops in pH and increases in CO2 don't stimulate their drive to breathe anymore because they're just so desensitized to the elevated levels. So the only thing that stimulates them to breathe is a lower oxygen concentration than what is normal with normal patients. So if we give them too much oxygen, we knock out their drive to breathe.